A very good evening to one and all present with us today. I am Arpita from the IGCP group. The topic that we have brought today in our webinar is Advances in Regional Anesthesia Techniques, Benefits and Challenges. And of course, we have someone with us very eminent in this field. Sir, of course, doesn't need any introduction, but to start with the session, I would like to welcome him, and it's a pleasure for me to introduce him to everyone. Dr. Nishant Kumar sir. He has done MBBS, post that he has done DA, then DNB, MNA, MS. He is a professor, Department of Anesthesiology at the Lady Hardin Medical College and the associated hospitals. So, with this very brief introduction of him, I would now request sir to please start with his topic. Over to you, sir.
Very good evening, and thank you, Arpita, for the kind introduction. So, today we'll be talking about advances in regional anesthesia techniques, benefits, and challenges. Now, we know that regional anesthesia is quite a fad nowadays. To start with, I have got absolutely no disclosures, and some of the images may be from Google, guilty as charged, but then these are the free images and without any copyright protection. And wherever I have taken images, those are from PubIndex journals and they have been appropriately cited. Okay. So the objectives of this today's talk would be the nomenclature that we follow for the regional blocks, how safe they are, what are the technical advances in that we have seen, the drugs, use of artificial intelligence, the techniques, and how we can further the training or improve the training. So they say that if you have to look at the future, you should know your history first. Only then you can improve. So we started with esters, which, despite a risk of allergic reactions, are widely used. Cocaine, the only vasoconstrictor local anesthetic, was derived from erythroxylin coca bush and was widely used as a topical ophthalmic anesthetic first, and then we moved on to procaine, amitrocaine, lignocaine, which changed the LA history. Then came the mepivacaine, prilocaine, the most widely used drug today, bupivacaine, followed by ropivacaine, levobupivacaine, and the newer drugs which I'll be talking about. Now, when we talk of regional anesthesia, it is very important that we speak the same language. So, we have to have a common nomenclature for most of the blocks. I say tomato, you say tomato. So, we are talking about practically the same thing, or whether it's half air, half water, or completely full. So, it's just a perspective, but it is important that we speak the same language so that there are no communication lags and there is no confusion per se about the blocks that we want to give. Now I say PEX 1, you want to say PEX 2. Now, unfortunately, the terminology has been changed and it has been decided based on the needle tip, the structure seen on ultrasound, and where exactly the drug is being deposited. So, if you go through this particular and excellent article of in Regional Anesthesia in Medicine of 2021, so this is the nomenclature now for most of the abdominal blocks. Now, if you see lateral tap block and MTAPA are now collectively called MTAPA. So there is no lateral tap block now. Similarly, the posterior tap block is now called lateral quadratus lumborum block, and rhomboid intercostal subserratus plane block and rhomboid intercostal plane block. Since the drug deposition is the same, the needle tip is the same, it is rhomboid intercostal plane block. Similarly, we have the nomenclature for paraspinal blocks, whereas the multifidus, cervical intersemispinal, paraspinal, and cervical paraspinal interfacial plane blocks. Unfortunately, they could not decide whether these have to be kept as individual or we continue with the name of cervical paraspinal interfacial plane blocks. But then we look at thoracolumbar the clip block and lumbar multifidus plane block. So again, there was no consensus here, but intertransverse process block has been named as intertransverse process block. Erector spinal block, retrolaminar block, and paravertebral block remain the same. So that is how it has been evolving. And now, as the example which I told you, the PEC one is now unfortunately called the interpectoral plane block. Rightly so, because we are depositing the drug between the two pectori. Similarly, the PEC2 block, where the drug was being deposited between the pectoralis major and serratus anterior, it is now called as pectoserratus plane block instead of PEX2 block, and it's the same thing whether it is PEC2 pectoral nerve blocks 2, PEX2, pectoserratus plane block, or depectoralis plane block. It is one and the same thing, which is now named as pectoserratus plane block. So that is why it is important. And similarly, the nomenclature has been decided for the upper limb. Now this was again in RAPM in 2023. So we have the 13 upper limb blocks and anatomical descriptions, which aptly describe the needle position and the drug deposition. And then we have approximately 25 lower limb blocks, which are now described and are in use. So we have a common nomenclature for all these blocks, and we know where exactly our needle is supposed to be. Now, regional anesthesia was being widely used for acute pain, postoperative pain initially, then came for surgeries, but it is more than that. So there is sufficient literature which proves that the use of regional anesthesia, even with the general anesthesia, reduces patient mortality, reduces major morbidity such as pulmonary complications, transfusion requirements, etc., and thereby results in economic outcomes such as length of hospital stay, which most of our administrators are interested in. Also, there is sufficient evidence to prove that in oncosurgeries, the use of regional anesthesia reduces cancer recurrence. There is definite mechanistic evidence for inhibition of tumor cell growth and seeding. Then there is suppression of the adrenergic and inflammatory response to surgery. We all know that. There's direct action of systemic local anesthetics on tumor cell apoptosis. Now, that doesn't mean that it gives bupivacaine IV, but then obviously there is some systemic absorption of the local anesthetic from the site where you have administered it. And indirectly, opioids have been implicated. Basically, the excessive use of opioids has been implicated in cancer recurrence. Now, when we are using regional anesthesia, one of the benefits is that we cut down on opioids. So, indirectly, because we are cutting down on opioids, we are causing less of cancer recurrence. Obviously, since there is less acute pain, there is a reduced risk of persistent postoperative pain, and most of the techniques are now being used to diagnose and treat chronic pain as well. So it is not just the acute pain, but all these benefits of regional anesthesia. So, what is the ideal technique? You should have an adequate motor block with adequate depth and duration for surgery. Excellent analgesia, be it surgery, be it postoperative. It should be easy to perform. So the landmarks or the target should be approachable, and you should be able to see an objective sign of success, and obviously it should be safe without any major complications. Regarding the drugs that we use, it should be easily available, inexpensive, and again cause the least toxicity that it can. Now, when we talk of safety, so nowadays is the we talk of safety in terms of neuroprotection. So it is not only the last that is obviously there, well established, how we can prevent last, that is by preventing the intravascular injection and limiting dosages, adding additives, blah, blah, blah. But where exactly your tip should lie? So basically, the idea is not to damage the nerve with your needle. So it should be somewhere between the paraneurium and the uh, endoneurium. So that is exactly here where your needle should lie and the LA should be deposited. Because if you go too deep in, okay, if you enter the fascicle, just if you go sub epineural, that is also a bit acceptable. But then when you're going through that, you can still injure the nerve fascicle. So this is the space where your drug should lie, right? So that is how you can avoid it. Now, obviously, ultrasound has made things very easy, okay, but then there is a there was this study which showed that the actual incidence of nerve injury with the needle per se is very less, whether we use PNS or we use ultrasound, or even if we combine both the techniques. So the idea is not to injure the nerve. So obviously, ultrasound definitely helps in that. And then we have physical probe mounted needle guides, so that we visualize it, we keep the structure of interest in the center of the probe, and then we place a mount, and then we just pass the needle through it at an angle of 45 degrees and making an isosceles, or rather a right angle triangle, so that we reach the exact point without having to worry about the needle tip. And for that, we have textured ecogenic needles, as you can see. Then we have the combined ecogenic and stimulating needles. As I said, it was initially thought that okay, ultrasound is gold standard. Then we said no, okay, we might still be intraplastic. We don't know. The tip may not be clear, so we should combine both the techniques. But then the incidence is more or so fine, the same. The nerve injury is almost the same. And obviously, then we have advances in the ultrasound, where we have multiplanar, three-dimensional, and four-dimensional ultrasound imaging. Then, furthermore, we have elastography, that is to differentiate the neural structures from the surrounding tissue. At times you're not sure, okay, this looks like a nerve, maybe it's a bit hyper or hypoechoic, so probably this is the nerve. So we have the acoustic radiation force imaging, which is shear wave elastography, which uh, differentiates as we give the fluid, or because of the tissue intensity, the structures appear different, and the needle is differentiated from the surrounding structures, and we can have a proper where exactly is the nerve, which one is the muscle, which one is the vessel. So based on the different elastic properties, the acoustic radiation, we have the different uh, structures in a different color. Now, as I said about guidance, so these are the different techniques, all these different techniques. We started with the blind, then we started with neurostimulation, then nerve paresthesia with muscle contraction, then intraneural injection again can, as I said, cannot be avoided. We started with ultrasound. Uh, Again, it says that intraneural injection cannot be avoided. Then we combine both the things. Then we have the optical techniques. So we have magnetic guidance, we have pressure guidance, we have video visualization guidance, we have EMG guidance, we have OCT guidance, and we have the AI guidance. And further such techniques are nowadays emerging. So something, the needle beam alignment, that is electromagnetic tracking, so that we can see the needle tip better. We have the camera tracking, we have the fiber optic hydrophones, and then we have something called as a piezoelectric sensor close to the needle tip, which is the Stimuplex on Vision V Braun. And as you can see here, the circle shows you where exactly your needle tip lies, right? So it has a piezoelectric crystal, and on the basis of that, where exactly your needle tip lies is denoted by this green signal, right? So, as I said, that the neural injury is not just by the needle injury, it is mainly the pressure or the local anesthetic which we are injecting can also cause nerve injury. So it is very important that we monitor the pressure at which we are injecting the drug. So again, neurostimulation. When we are doing neurostimulation, it is said that the opening pressure in excess of 15 psi, if you have to apply too much of pressure, you'll cause nerve injury. So we can use a half air technique with a three-way syringe, and we can attach these valves. Now this will give you the exact pressure at which you are injecting. This one is a pressure limiting device which won't let you inject the drug if the pressure is beyond 20 psi. Then we have something called as Safira when you're doing it alone. Now this is a more like an infusion pump with a pressure limiting device. Again, does not let you inject beyond 20 psi. So this is a foot pedal. You just mount the drug here, switch it on. The yellow one is for aspiration, and this one is for infusion. And if the pressure is more than 20 psi, even if you press on this pedal, it won't be injected. Then the continuous techniques. Obviously, we have all said catheters have come, gone. We have said that catheters are not easily visualized, they get displaced. So there have been some advances. We have catheter over needle. Now, what we do is we pass the catheter through the needle. Now, the advantage of catheter over needle devices is that it is a snug fit, higher injected pressures, and specifically for continuous continuous spinal techniques, because the catheter goes over the needle, so the leakage is much less chances of PDPH. Then we have the suture style catheters, in which these are the catheters with echogenic marking. Sorry, this seems to have a mind of its own. So we have this suture needle, which is echogenic, and then we have the catheter. As it passes through the catheter, we can see the echogenic markings of the catheter. So exactly we know where our orifice lies and where our catheter lies. So this is what it looks like, and this can be again be put under ultrasound guidance. So not only the needle, but the catheter also can be visualized under ultrasound. Obviously, then we have something called as AI, which has image recognition technology. I mean, you have to be really a master of anatomy to understand the ultrasound images. But then you place the probe, you have the library, the computer recognizes, okay, this is this muscle, this is this muscle, this is a nerve, here is the nerve. So this can be done on the basis of deep learning, image classification, object detection, and segmentation. And we already have machine learning models for femoral nerve and brachial plexus. Now, if you can see here, this is for your adductor canal block, and here you can see where is the artery, where is the nerve. It tells you exactly where it is. And then obviously nerve blocks have been tried with robotic assistants. Da Vinci and Magellan have been used to deliver the nerve blocks using ultrasound guidance. And then instead of following the patient by phone or by interview or by calling them for the to the clinics, we have uh, apps. We have an app for everything, right? So we have an app for this also, where the patient can report any complications, any problems that they have directly on the app, and you can record, and it's an instant record as well. So you don't have to enter the data yourself. So maybe that's the future. Coming to the drugs, liposomal bupivacaine, it's a missile creating a bilayer of lipids with bupivacaine inside. Slower release prolongs the analgesic effect, and it has been said that it can provide analgesia up to 96 hours, but the evidence has been not so good so far. Then we have the bupivacaine meloxicam combination in prolonged release formulation, action up to 72 hours, and it is applied needle free into a surgical site. So basically, you give it to the surgeon just spread this onto the surgical site, and you may have analgesia up to 72 hours. Mepivacaine, prilocaine made a resurgence, but then have not been heard of again. Uh, Sorry. Yeah. Then we have the QXOH and levobupivacaine combination, LL1 combination. So basically, QXOH is a quaternary lignocaine derivative plus levobupivacaine, which has fixed dose combination, which has good efficacy in fast onset. And these two drugs provide additive effect of inhibition of sodium current, so longer analgesia. Now again, this is in the third phase as yet, not available in the market, but then maybe you'll be using that in another couple of years for all we know. Then we have the hydrogel microsphere composite of bupivacaine and dexmedetomidine. So we are now routinely adding dexmed to our bupivacaine. So instead of adding it to the syringe and then waiting, okay, fine, this will act, we have a hydrogel microsphere composite, and dexmedetomidine constrict local arteries to reduce bupivacaine uptake, and bupivacaine is released over a longer period of time. So longer duration, less systemic toxicity. So you have two cakes in both your hands. And then we have the injectable electrospun fiber hydrogel composite. So this is E-caprolactone with ropivacaine and F127 hydrogel. Again, the hydrogel is loaded with clonidine. So same mechanism. So here we have ropivacaine and clonidine, sensory up to 32 hours, motor up to 20 hours. So again, in phase 3, uh, now when we talk of additives, we all like to add additives. They're except for I think propofol or thiopentone, there has no drug which has been spared as an additive to the local anesthetic. Now, this is something new neurotoxin in shellfish, new saxitoxin, reversibly blocks voltage gated sodium channels, showed promised, but unfortunately has not continued beyond the first phase trials. Now, the most common additives that have been presumed to be safe and provide long-lasting analgesia is dexmedetomidine, prolonged duration by 4 to 5 hours, and optimal dose is 50 to 60 micrograms in an adult, and dexamethasone, obviously preservative free, can be given IV or perineurally, but then we have seen that perineurally performs a bit better than IV, and if given IV, decreases postoperative nausea or vomiting. So the mechanism of action everyone knows, and increases the duration by around 5 hours. Now, what is the dose? 1 milligram, 2 milligrams, 3 milligrams, 5 milligrams, 8 milligrams. So, they say around 3 to 5 milligrams is an optimal dose of dexamethasone for the local anesthetic to be prolonging the action. Then we have the good old adrenaline, obviously, the obvious side effects. Then clonidine, sedation, hypertension, bradycardia, not commonly used. Buprenorphine, no, excellent drug, but then causes an intense increase in nausea and vomiting, so maybe a limiting factor. So that leaves us with dexmedetomidine and dexamethasone as the ideal additives. So one of my colleagues, one of our anesthesia colleagues has said, "Show me a nerve and I'll block it." Ultrasound has practically made it possible. And to that, I've added that if a nerve can be blocked, it should be. So whether you're giving general anesthesia or any other form of anesthesia, if you can block a nerve, please do so because of the advantages which I mentioned at the beginning. So please don't withhold regional anesthesia. If you can administer a block, please do so, and you'll see the difference. So with that, we have new kids on the block, facial plane blocks, that is serratus posterior superior muscle block, rhomboid intercostal plane block, and deep serratus anterior plane block for mastectomies and chest wall surgeries, MTAPA for anterior chest wall surgeries, quill blocks for your um, upper and lower abdominal surgeries. Then for the shoulder surgeries, we have diaphragm sparing blocks such as suprascapular nerve block, plus the infraclavicular or the upper trunk block, and entire surgery, the shoulder surgeries can be performed under these blocks per se. For clavicle surgery, we have cervical plexus, supraclavicular nerve, or the scut block, and for fractures, in fact, cervical plexus and clavipectoral fascia block can really give the surgery or plating done without any general requirement of general anesthesia. For total knee arthroplasty, we have IPAC and genicular nerve blocks, which can be explored. Now, if I go into the detail of each block, that is another talk altogether. Now, when we talk of central neuraxial blocks, unilateral spinal anesthesia have been trying, but I don't know continuous spinal anesthesia. I've already talked about the newer catheters which are available, and the latest fad, thoracic segmental spinal anesthesia. So I don't know. Evidence is still evolving, but then everyone wants to try that. We'll have to wait and see. Rapid sequence spinal anesthesia are not very new, more so basically in obstetric cases wherein you take aseptic precautions but don't waste time. Then we have the epidural volume expansion for gradual for fast increase in block, and CSF lavage. Now, recently there had been reports of tranexamic acid being given instead of bupivacaine, hyperbaric bupivacaine, because of look-alike drugs. So CSF lavage has been advocated if you accidentally uh, administer the wrong drug, or if you want to wean off the effect of the drug fast. So what you do is you insert a spinal needle, um, inject saline, aspirate CSF, inject saline, aspirate CSF. So that probably may speed up the elimination of the intended drug. So that is one thing can be tried around 15 ml, 5 ml, three times it can be tried this way. Then we come to regional anesthesia cardiac surgery. As I said, if a nerve can be blocked, please do it. So the obvious choices earlier were central and rectal blocks, but obviously with anticoagulation and other factors, we don't go in for that. But thoracic segmental spinal anesthesia now again is coming up. I don't know how successful or how good it might be, but those practicing cardiac anesthesia may comment on that. Now, the obvious choices come down to thoracic paravertebral and erectospinal plane block, which have been studied and have proved beneficial in cardiac surgery. And obviously, the new facial plane blocks, we have PEX, SAP, parasternal intercostal plane block, and obviously the rhomboid intercostal plane block, and uh, the serratus posterior superior muscle block, which I told about earlier. So maybe these can play a role with all the newer drugs, longer acting drugs which are coming out. So yes, cardiac surgery is not a contraindication for regional block, or rather regional anesthesia is not a contraindication for cardiac surgery. Sorry. Then please remember, age is not a bar for regional anesthesia. Now we are worried about all these complications in the pediatric age group. Don't be, uh, don't worry, and we are worried about toxicity. So we have a guide of whatever drug that we are using, how much drug we can use for that particular child safely. And central neurethral block is safe in children. I've used it even in a neonate and gives as a sole anesthetic, by the way, and it gives excellent results. Obviously, as a word of caution, it is always better that if you give all the blocks in children USD guided. Now, there are certain blocks uh, which can be used exclusively in children for particular surgeries. Supraorbital and supratrochlear nerve for eye surgeries, infraorbital nerve for cleft lip, greater palatine nerve for palate, and superficial cervical plexus blocks for surgeries around the neck, mastoid, and ear. So all these blocks are simple to give with the ultrasound. They are very safe and can be administered easily. Please don't withhold blocks in children. They feel as much pain as we do, and sometimes more. So, the notion that small children, infants, neonates don't feel pain is uh, the greatest crime an anesthesiologist can commit. Please, children deserve adequate anesthesia. Don't withhold regional anesthesia just because of the complications and the fear of toxicity. You have to be safe, you have to be careful, you have to be an expert to administer drugs to children, but then that is what should be practiced. Now, coming to training, uh, it is not just learning the skills. So, we should have the cognitive skills, we should have the behavioral skills, and then we should have the technical skills. So, it's not just only the technical skills which are important. The cognitive skills and the behavioral skills are as important, and all these have to be taught to the trainees. Similarly, when we talk of training, we have the Dreyfus and Dreyfus system and the Anita Harrow taxonomy. So, you start with novice and you become an expert, and at the same time, we have a guided response and we have confidence with the movement, highly coordinated performance, modify movement patterns to address difficult situations, and movement patterns to address specific problems. So, this is how you become an expert and a guided response, right? So that is how you go to the highest level, and that is what we should uh, aim at. So we should aim at all those things, right? So we have learning, seeing, practicing, probing, doing, and minting. So these are the things that you have to achieve in a trainee to say that he or she has been successfully trained in regional anesthesia. How do we ascertain success in regional anesthesia? At the level of the patient? Patient is happy. Population means that okay, this particular block is working for a particular group of surgeries. Yes, this is something that we can do and practice in day-to-day cases. Healthcare, when we bring down the cost, we bring down the stay in the hospital, we see obvious results in terms healthcare always in terms of economics, unfortunately. But then when the stay is reduced, when the stay is reduced, the costs are reduced, complications are reduced. That is your healthcare system, and obviously, then whether you are able to train or propagate the knowledge which you have, the skills which you have to the future generations, that is your success. Thank you so much for your time, and I'm open to questions.
Thank you, sir. Thank you so much for the beautiful presentation. Now, I would request all the audiences who are with us, if you have any questions, please put them up so that I can read them on your behalf. Meanwhile, I have received a few questions which I would like to present to sir. So the first question is, can you discuss the role of regional anesthesia in multimodal pain management, particularly in context of enhanced recovery protocols?
So that is what I said. When we are talking of enhanced recovery protocol after surgery, regional anesthesia plays a definite role. Acute pain, anti-inflammatory effect, less post-operative complications, less use of opioids. You require lesser muscle relaxants. You require lesser dose of anesthesia, so recovery is faster. The length of stay in the hospital is decreased, and the discharge is faster. So obviously that's the whole point of renal anesthesia. When I said that it should not be withheld whenever it can be administered.
Right, sir. Thank you so much. The next question is, with advancements in nerve monitoring and block techniques, what are the potential risks or complications that practitioners should remain vigilant about, and how those can be mitigated?
So, as I said, you have to acquire the skills, you should have the equipment. The nerve injuries, that is the most dreaded complication, but then with ultrasound, with neurostimulation, and pressure monitoring, even if you don't go on for the advanced techniques, these are sufficient. Obviously, there are going to be complications, and obviously, you have to avoid last. So, whenever you're performing a block, please keep lipid emulsion with you. I've not discussed the last guidelines because everyone knows about them, but then you should be familiar with last, and obviously stop before block. That is that it is sort of a WHO, the sort of a WHO checklist that we perform before surgery. You identify and you don't administer the block on the right side for the correct patient and for the correct surgery, and say out loud which drug has been loaded, see the ampules, and then administer the block and the block which was intended for that particular patient.
Sir, we have received two more questions, and post that I think we can close the session. The
Sure.
question is, how has the use of ultrasound guided regional anesthesia changed the precision and safety of nerve blocks in your practice?
So now, as I said, I'll echo the words of my colleague. Show me a nerve and I'll block it. So that is the thing which what ultrasound has done, and all the new blocks that have been described, the facial plane blocks, which are not possible otherwise, definitely they are much safer. Although the volume that we give is higher in facial plane blocks, but then we are away from the nerve. We are filling up the interfacial space with the local anesthetic where the nerves lie, and we can achieve analgesia and anesthesia for surgeries in which opioids were the only answer before ultrasound. And obviously, no radiation, safe to use, easy to use, and you're performing it under vision. And you know, even if your needle moves slightly, even by a millimeter, you know your drug thread is not where it is going to be. So the precision has increased, and obviously, with that, safety has increased.
Right. So the last question for today, that is, what are the key challenges anesthesiologists face when implementing newer regional anesthesia techniques, especially in resource-limited settings?
Okay, so I knew. So the first thing is acquisition of the ultrasound, the PNDT Act, the medical legal problems when you're facing the problems with the patient who has neurological deficits. So the idea is that you can start now. The peripheral nerve stimulators are coming for as low as 10,000 to 20,000 rupees. So earlier, which used to cost lakhs, and so you can follow landmark techniques. Obviously, they are a bit difficult. There are chances of more chances of nerve injury. I wouldn't say that it will cause nerve injury, but then use of peripheral nerve stimulators, even if you don't have ultrasound, um, and practice. So that is how you evolve. Practice, 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 and you might have failures, but then you understand what you have done wrong, You learn from your mistakes and you move on and improve your skills and benefit the patients. So that is the only advice I look out for resource limited science. Again, just because of non-availability of ultrasound, please do not withhold notes wherever you can.
Right, sir. Thank you, sir. Thank you so much for clearing all the doubts of our audiences. And with this, we come to an end of the session. So I would like to extend my heartful thanks to you for your engaging and very insightful presentation. And of course, I'm very confident that the knowledge that you have shared will be a great use to all the viewers. So once again, sir, thank you so much for your precious time and for making this session such a productive one. Thank you, sir. Thank you so much. With this, we would like to conclude the session. Thank you all.
Thank you so much. Thank you.